Let's talk about type 2 hypersensitivity reaction. Type 2 hypersensitivity happens when antibodies, usually IgG or IgM, bind to antigens that are fixed in place. That is the key idea. The target is attached to a cell surface or embedded in the extracellular matrix. This is how you distinguish it from type 3 hypersensitivity. In type 3, immune complexes are floating around in circulation and then deposit. In type 2, the antibody binds directly to something that is already fixed in tissue. Once that antibody binds, three major outcomes are possible: cellular destruction, inflammation, cellular dysfunction. Three major outcomes are: number 1, cellular destruction; number 2, inflammation; number 3, cellular dysfunction. Same trigger, antibody binding, but very different consequences depending on what immune mechanisms get activated. So let's go through each one carefully. First, cellular destruction. Here, a cell becomes opsonized. That means it is coated with antibody. Once coated, the immune system recognizes it as a target. Why does opsonization cause destruction? Because immune cells recognize the Fc portion, the tail of the antibody. That labeling tells the immune system, remove this cell. So there are two main routes of destruction. Route 1 is phagocytosis and/or complement activation. Macrophages, especially in the spleen and liver, have Fc receptors that bind antibody-coated cells. Once they bind, they phagocytose and clear those cells. IgG or IgM bound to the cell surface can also activate the complement system. Complement contributes in two ways. It can directly injure cells via the membrane attack complex in some settings, or it can tag cells for removal through opsonization, especially via C3b. Route 2 is NK cell killing, antibody-dependent cellular cytotoxicity or ADCC. In this mechanism, NK cells bind the Fc portion of the IgG attached to the abnormal cell. The NK cell then triggers cytotoxic killing. This is classic ADCC, a favorite USMLE concept. Now, let's anchor this with must-know examples of type 2 cellular destruction. Autoimmune hemolytic anemia, including drug-induced forms. Antibodies coat red blood cells, leading to hemolysis or splenic clearance. Immune thrombocytopenia. Antibodies coat platelets, leading to platelet destruction and low platelet count. Another one, transfusion reactions. Antibodies bind transfused red blood cell antigens, leading to hemolysis. Next one, hemolytic disease of the newborn. Maternal antibodies bind fetal red blood cells, causing hemolysis. So quick exam tip: if you hear antibodies against blood cells, think type 2 cellular destruction. The second outcome is inflammation. In this version of type 2, antibodies bind to tissue structures, often components of the extracellular matrix like basement membrane. Instead of primarily removing cells, the binding activates the complement system and Fc receptor mediated inflammation. Why does antibody binding cause inflammation instead of simple destruction? Because complement generates inflammatory signals, especially C3a and C5a. These recruit and activate neutrophils. Neutrophils then release enzymes and reactive oxygen species that damage tissue. So here the problem is not clear this cell. The problem is inflammation damages the tissue. So classic examples of type 2 hypersensitivity inflammation are Goodpasture syndrome. Antibodies bind basement membrane components in kidney and lung. Complement activation leads to inflammation and tissue damage. On biopsy, you see linear immunofluorescence along the basement membrane. The next example is rheumatic fever. Antibodies cross-react with host tissues after streptococcal infection, leading to inflammatory injury, including heart involvement. The next example is hyperacute transplant rejection. Preformed recipient antibodies bind graft endothelium immediately after transplantation. Complement activation leads to rapid inflammatory damage and often thrombosis-like injury. So the key pattern here is antibodies bind tissue targets, complement activation plus Fc receptor mediated inflammation, leading to tissue injury. Okay, the third possible major outcome for type 2 hypersensitivity is cellular dysfunction. This is one of the most high-yield concepts in type 2. Here, the cell does not have to be destroyed. Instead, antibodies bind to cell surface receptors and alter their function. Why dysfunction instead of destruction? Because the antibodies act like drugs. They can either block the receptor, acting like an antagonist, or activate the receptor, acting like an agonist. The cell remains alive, but signaling is abnormal. So the classic examples are myasthenia gravis. Antibodies bind acetylcholine receptors at the neuromuscular junction, blocking the signaling. The result is muscle weakness that worsens with use and improves with rest. Symptoms improve with acetylcholine esterase inhibitors. Another example is Graves' disease. Antibodies bind the TSH receptor and activate it. This causes abnormal activation of downstream signaling and increased thyroid hormone production. Patients have heat intolerance, weight loss, low TSH, high T3 and T4, and often exophthalmos. Okay, the next example is pemphigus vulgaris. Antibodies target cell surface adhesion molecules, disrupting cell adhesion. And the result is flaccid blisters and a positive Nikolsky sign. Positive Nikolsky sign means that when you gently rub or apply lateral pressure to the skin, the outer layer of the skin shears off. In simple terms, light rubbing causes skin to peel away, so it tells you that the epidermal cells are not sticking together properly. Okay, so remember, in type 2, antibodies can destroy cells, inflame tissue, or cause dysfunction, depending on the target and mechanism. Now let's talk briefly about the Coombs tests, which are very testable. So these specifically evaluate antibodies directed against red blood cells. The direct Coombs test detects antibodies that are already attached to the RBC surface. This tells you that red blood cells in the patient are coated with antibody. Indirect Coombs test. The indirect Coombs test detects unbound antibodies circulating in the serum. This is used for transfusion compatibility testing and pregnancy-related antibody screening. So, to memorize, direct Coombs is to test antibodies stuck on the RBC surface. Indirect Coombs test is to test unbound antibodies floating in the serum. Okay, now let's apply this knowledge with some mini quizzes. For each case, ask, is this destruction, inflammation, or dysfunction? Okay, number 1. A 28-year-old woman develops fatigue and jaundice after starting a new antibiotic. She has anemia and elevated indirect bilirubin. Antibodies are attached directly to RBCs. So, this is cellular destruction, drug-induced autoimmune hemolytic anemia with a positive direct Coombs test. The next example, a patient develops fever, flank pain, and dark urine. minutes after a blood transfusion. This is definitely cellular destruction, transfusion reaction hemolysis. Okay, another one, a newborn with jaundice and anemia born to an Rh negative mother and Rh positive baby. This is definitely cellular destruction, hemolytic disease of the newborn. Next one, a patient with hemoptysis and hematuria and linear immunofluorescence along basement membrane. Of course, this is inflammation, Goodpasture syndrome. Next, a transplanted kidney immediately becomes cyanotic and fails in a recipient with preformed antibodies. Of course, this is inflammation, hyperacute transplant rejection. Okay, the next, a young woman with progressive muscle weakness that improves with rest and response to acetylcholinesterase inhibitors. This is cellular dysfunction, myasthenia gravis. Another patient with heat intolerance, weight loss, exophthalmos, low TSH and high T3T4. This is cellular dysfunction, Graves' disease. Next, a patient with flaccid blisters and a positive Nikolsky's sign. This is pemphigus vulgaris, cellular dysfunction. Another one, a child with petechiae, mucosal bleeding, and isolated thrombocytopenia. This is immune thrombocytopenia, cellular destruction. Next, a patient with migratory polyarthritis and a new murmur weeks after a sore throat. Of course, this is rheumatic fever, inflammation. Okay, let's close with rapid recognition checkpoints. When you see antibodies binding to a fixed target, a cell surface or extracellular matrix, think type 2. Then ask, is this cellular destruction? Think RBCs and platelets, autoimmune hemolytic anemia, immune thrombocytopenia, transfusion reactions, hemolytic disease of newborn. Okay, or is this inflammation? Think about tissue binding with complement activation. Example, Goodpasture syndrome, rheumatic fever, hyperacute transplant rejection. Or is this cellular dysfunction? Think receptor blockade or activation, myasthenia gravis, Graves' disease, pemphigus vulgaris, etc. And if the question mentions Coombs testing, direct Coombs means antibodies are already attached to RBCs. Indirect Coombs means antibodies are circulating in serum. If you internalize that flow, fixed target, antibody binding, and then classify into destruction, inflammation, or dysfunction, you will answer type 2 questions calmly and correctly on the exam day. And that is type 2 hypersensitivity reaction. Thank you very much and have a very wonderful day.